Welcome to Where is the Money in Value-Based Contracting? I'll start by introducing our panelists. Let's meet them. Kelly Conroy, if you could raise your hand just to identify. Senior Advisor and Consultant with Pinnacle. Kelly brings more than 30 years in healthcare finance management and consulting experience. She started the first Medicare ACO in the country, Palm Beach ACO, which delivered nearly $40 million in savings in its first year. And from there, she has gone on to manage some of the most profitable ACOs in the country, including Aledade and Trinity ACOs. Jonah Brulette, Principal and Consulting Actuary with Milliman. Jonah develops and evaluates risk contracts and alternative payment frameworks between payers and providers. Deep work across Medicare programs, including BPCI, Pioneer ACO, NextGen ACO, MSSP, Direct Contracting, and ACO Reach. He played a key role in Milliman products like ACO Insight and ACO Builder. Derek Pauly, President, COO, and CIO of Physicians ACO and Citrus ACO, President and CIO of Blue Sky Analytics, a founding team member of Palm Beach ACO. Derek has developed and managed over 20 ACOs. His organizations have led the nation in ACO savings rates. For example, Citrus ACO in 2019, and Blue Sky's clients, which does the data analytics, have saved Medicare over $750 million. And then lastly, but not lastly, Juliet Price, Chief Solutions Officer for HSG. Juliet designs data-informed, value-based care models and has led extremely complex contract negotiations for providers, payers, startups, government agencies, and social service partners, advancing better patient outcomes and reducing cost. Please join me in welcoming our panel. All right, so where is the money in value-based contracting? We know that the passion for value-based care is the aim of better quality and better outcomes for patients. But many providers, nonetheless, they still prefer fee-for-service over value-based care because they're generally paid regardless of cost, quality, or necessity. If fee-for-service providers are to voluntarily step into risk, and if value providers already in the game are to thrive after having already stepped in it, then the present and future whereabouts of money in value-based care will need to be pinpointed. Our panel has some ideas on these fronts. In our preliminary conversations before the panel, two realities came to bear. First, engaging specialists is not optional if you want to bend the cost curve. You'll see later on a simple specialty spend visual slide in the deck. It'll help make the point. Second, the money is real when the operations line up. We heard about double-digit savings under reach, even as rules tighten and the easy arbitrage closes. So the how is evolving. While adoption may lag, policy is maturing fast and faster. CMS is signaling winners and losers. This means more competition and a push to hold risk closer to the physicians. Quality measurement is slated to change in 2026, so we'll hear from the panelists on both the macro picture and the micro picture to make this location of the money practical. So I guess we start off first with Derek, since you're our practitioner here, or you're actually on the ground. Where do we see organizations, I guess, where have you actually seen success at capturing the money that's available in the value-based care model?
Yeah, thank you. It's an honor to be here on this panel. I just wanted to say Citrus ACO was also number one in savings rate in 2023 and 24, and then Physicians ACO was number one in 2021. And I mean, there's two big aspects that we see that are how we've been so successful in the ACO program. And the first is what we call the 5-star practice. It's primary care physicians keeping their arms around the flock, paying attention to quality measures, reducing unnecessary admissions, and then also we have the top 5%. So the 5% of your population consumes 50% of your healthcare expense. And so that is one area where you can really target if you have, let's say 10,000 patients, 500 of them consume half your benchmark of, let's say, $100 million. So 50 million of your spend comes from 500 patients. And so we have a lot of our efforts targeting those patients as kind of a low-hanging fruit, and that really has been successful for us. We've found that we have a physician outreach program that will send a provider out to the patient's home. We find that increasing the access to care that way really, really makes a difference. In addition to that, there's also social work that We look at the houses, how the patient's living and things like that, that really, really make a difference in our population.
What is there a small operational tweak that you feel like has saved you the most money? Like one particular play in your playbook that's been the most successful, you repeat over and over?
Yeah, I mean, it's really, taking care of the high cost patients, anything you can do there, keeping your arms around your flock. We look at all the key performance indicators, annual wellness visit rates, making sure our doctors see chronic conditions, patients with chronic conditions 4 times a year, transitional care management visits. If we can avoid a hospitalization, that really prevents so much downstream unnecessary expense where the patient's admitted to the hospital, they're there for 3 days, they're laying in bed, then they end up at a nursing home. While they're in the hospital, the specialists are doing consults on these patients, following up with them to go to their office and perform all of these diagnostic tests on the patients. Then they're in the nursing home. From the nursing home, they have home health. And then when they're discharged, they have a whole new medication regimen. And, they could get readmitted. So there's all of these things that can happen. And by us proactively trying to keep the patients unnecessarily out of the hospital, it prevents all of that downstream expense for the patients. And we find that that's been very, very successful from a benchmarking standpoint, reducing the overall total cost of care for our patient population. And we've achieved, a 22% savings rate in 2024 for Citrus ACO, which is pretty incredible. And so that's one thing that we do, and focusing on them and assigning the right clinical folks to case manage those patients is very helpful. And we have very engaged physicians. One of the things is that we've been so fortunate to be successful year after year after year. The doctors are engaged. They know that oh my gosh, it's working. Let's focus more. If we need to do this, let's go in it wholeheartedly and modify our operations to take care of this population or to change this approach. And that's just been tremendously successful for us.
A lot of success. What about where the money's not? What have you tried that just didn't work?
Well, we're going to talk about this in the future a little bit, where Kelly and Jonah and Juliet, I think. But really, we've struggled with specialists, to be honest. We feel that when the patient sees a specialist, they're going to do what they're going to do. You can try to have a fee for service reduction agreement, save a little bit there. But once they're in the specialist office, the specialists are going to run their tests. If there's an indication for something, they're going to do it. And so what we try to do is provide as much as we can in the primary care office, keep the patients out of the hospital. And we find that that's been pretty successful. We just haven't found that magic formula to get specialists engaged to perhaps be more conservative or work on, or try alternative treatments that are more cost effective.
Okay. Jonah, anything you want to round out there from what he's describing?
Yeah, certainly. I look at it from an actuarial perspective. So what I spend my time doing is consulting to entities who are taking risk in these programs and identifying kind of 2 phases. Programmatically, where there's opportunity for savings. Am I participating in this program responsibly? And what can I know about my participation in this program and how I'm going to generate revenue? What are the things I know and what are the things I don't know? From my perspective, in sort of where the money has been to date, I think as Derek points out, there are ACOs. I think there's 2 main ways that we can generate money in these programs. There's programmatic participation, so understanding the program, participating with the right providers, taking advantage of those providers who are already well suited to take risk, i.e. they're already quite efficient. They've already demonstrated more efficiency than the market at large. And making sure that your patients are represented with the appropriate risk, making sure you're getting a fair benchmark for the patients you're taking, or even an advantageous benchmark for the patients you're taking risk for. So that's bucket 1. Bucket 2 is, I think, where we all see the vision of value-based care, which is reducing costs from historical levels, and generating savings for both CMS and yourself in the future. But I think both of those buckets have been engaged thus far in the programs. But it is both of those buckets. And I think where we see, and we have seen some critiques or questions over the savings we have generated today, it arises around the intersection of those two buckets. Bucket one, I think, is very required for participation and in the program and for, is important to get engagement and steady returns within the program. So we need to make sure that providers are aware of the risks they're taking, that the benchmark they're receiving for those patients is adequate, and that the risk for their patients is being adequately captured. But that isn't necessarily generating new savings on historical spend. I think ACOs that have been very successful, like those that Derek mentioned, have been doing both at the same time. And that's where we've seen the sort of outsized gains in the program. And that's really what we want to focus on moving forward. But I think what we see coming down the line, I think there will be less savings in future around bucket one and increasing focus on bucket two. And just to double down on something Derek said, I would agree that to date we have seen struggles with engaging specialists and with bringing them into the models. The attribution you get to specialists often does not meet that bucket one criteria. It is often underpriced. It is difficult to manage. And since, as Juliet mentioned very accurately, all the attribution right now is flowing through the primary cares. If we don't have a creative and a good way to engage specialists, as Derek said, when they go to the specialists are just going to do what they historically have done. So I think where we're at sort of in this inflection point, and likely what we certainly hear from the administration and what is likely to come, is we need models to engage downstream providers more than they historically have if we want to get into the second bucket of savings, which is where we all want to go, which is start changing how much care costs in this country relative to what it has in the past.
Thank you, Jonah. Kelly, specialists I know are a big passion item for you. You want to build up on what Jonah was beginning to describe there?
Yes, sure. So I think the PCPs have done a great job in the last decade controlling cost, getting themselves together. I remember in the early days when we started Palm Beach ACO, we were very focused on the fact that we needed 5,000 patients. We didn't know what that meant. We needed 5,000 patients attributed to us. So we were sort of in this boat. Not only were we in the boat where we had one foot in a canoe that was fee-for-service, we had a foot in a canoe that was trying to be value-based care, which we didn't understand back in those days, just trying to get 5,000 patients. We now understand how to get those 5,000 patients, but we're just trying to row, like we're rowing in a circle because we've completely left the specialist out of it due to attribution and due to no incentive for them. The whole program was built on who's taking care of these patients. And the irony to me, and one of the biggest regrets of making ACOs and building ACOs for the last decade, is we didn't include the patient. The government didn't include the patient, and we didn't include the patient either. I do think that's coming. Juliet kind of foreshadowed that the government realizes that was a big miss. So we'll hopefully have some more patient involvement. If they only knew what we were trying to do, I think they would actually help us.
Yeah.
You know, instead of working, we're working around them. And I have seen in the last year, I'm starting to hear patients ask, "Can I be in an ACO? How do I get an ACO? This sounds really good." But it's not going to be great if we're still just trying to do it around the PCPs. So we do have one slide, I think. Well, I should let Jonah explain it, but this is why the specialists matter. This is what we haven't been paying attention to. If you can see this slide, the top two things that are really causing all of the expenditure are these circulatory diseases and musculoskeletal. You can see this expense up there. And what we know, and this is a slide from Jonah, so maybe you can explain how the methodology of putting it together. But we know that the specialists are controlling about 70 to 80% of that. So if we don't find a way to get innovative, to unlock incentives to get the specialist involved, we're just going to continue to row in a circle, I believe. So I think we have some really good ideas about how to get specialists involved. There are some wonderful ACOs out there that actually started with specialists. So they've been since 10 years, 11 years. Palm Beach ACO is actually one of them. They've had specialists as owners in their ACO the whole time. So they've been collaborating, and they have figured out how to incentivize the specialists to help in this mission, which is pretty nice. I think if you'll go to the next slide, there's some new programs coming from the government that really are going to give teeth to the specialists getting involved. And the one I think I like the best, I don't think it's going to be a popular one, but is the ambulatory specialty model. The government has basically said for the last 2 years, if you don't fix this or find a way to include the specialist, we're going to fix it for you, as evidenced by these models that are right here on this screen. This ambulatory surgery model is going to focus on cardiology and low back pain. So Dr. Oz says that the highest cost is the low value treatment. So people that are getting low value treatment is a really big problem. We're spending a lot of money. So this is what they've come up with to fix it. I understand it's a buildup on both administrations. The last administration was trying to fix it, put together a framework, and this new administration is working together closely to actually put this framework out there. And to Juliet had mentioned this is a mandatory model that starts in 2027. So if you're on that list and you're a cardiologist or you're a musculoskeletal specialty, and you're on that list, you're just going to be thrown into this and you're going to get to figure it out. Here's the scary part. In typical government fashion, they never throw anything away. So they brushed out the old MACRA MIPS chassis to build this on top of. So remember in 2015, we started hearing that, in these new programs, these new quality programs, you're going to get plus or minus 9% on your fee for service, meaning the low performers were going to pay the high performers. Well, guess what? That's back, and here it is. The people in this ASM model are going to get plus or minus, is it 12% now? 12%. So the idea from the administration, Chris Klomp and Abe Sutton, is if you're good at it, you keep doing it, and you're going to get 12% more on fee for service. If you're not good at it, you should do something else, or you should find a better way. So they're really pushing it. As she said, they're pushing more people to risk, but they are trying to fix the specialty model for us. The next one is this GEO Ahead model, and I think this is going to be where we're really working with the states. So more to come on that, not coming out until 2028. The TEAMS model, this is an episode bundled type arrangement for 30 days on 5 procedures. I think the next panel is going to talk a lot about TEAMS. And then the last one I think is very interesting, and it's built over both administrations as well, is this WISER model, and it's meant to reduce fraud, waste, and abuse by using artificial intelligence. So they're going to use the power of technology to kind of suss that out. I mean, everybody probably is aware of the skin substitute fraud, waste, and abuse of last year. They've just addressed that in the new fee schedule, so that won't be a problem going forward, but they're going to find more things like this as they're doing it. And also tied to the WISER model is authorizations. They're going to now require authorizations in fee for service. And the idea is if you're good at it and you get a good grade on it, they're going to give you potentially a gold card so you don't need it. So I think the writing is on the wall. If we don't find some really good innovative ways to fix this, the government's going to fix it for us. Juliet, what about you?
Yeah, I think you said it absolutely correct, Kelly. I think for a long time, specialty and all the comments here have been leading up to this, which is, I think maybe the hypothesis before was like, the primary care providers will get so good at this that they will inevitably, like all that good behavior will inevitably leak into the specialty side of the house. And I think it was a hypothesis. Let's give credit where credit is due. It just hasn't worked out that way. I think, as I mentioned, primary care has had to do so much to get to the place where it is today, which I agree, Kelly. I think they've done a standout job. Primary care is not, I kind of say it's like not your mother's primary care anymore, nor will it be in another 5 years, right? I think this is where artificial intelligence, I believe, can have a big impact. We don't have enough primary care doctors today. We're not going to have any more in 10 years. And so how do we change what primary care looks like to be more comprehensive? So if that was the hypothesis, that this was just going to inevitably bleed over into specialty care, to your point, Kelly, it hasn't. And so this is, I just want to double down on what you said. This is the government saying like, okay, you guys didn't figure it out. Like, we're going to figure it out for you. And that is going to have some ramifications, right? These are their hypotheses. So we'll see where these programs go. But I think just as we've learned so much from MSSP and ACO REACH and direct contracting, we learn every time we do something different. And I think that's the real power of everything that CMMI does at the government level is this may not be where we ultimately end up, but we're going to learn something, right? And the actuaries are going to learn something and the providers are going to learn something, and we'll be smarter on the other side of it. And so I think this goes to my point that I made earlier, which is especially if you're on that list, if you're in a mandatory model, get started now. You shouldn't be waiting around, because every day that you don't do something, you miss an opportunity to learn and get smarter and better about what's happening. I think the other thing I would say is I think the lines that we have drawn around specialty are also moving. A lot of primary care physicians feel very nervous about if anybody slightly says something about their heart, it's direct to cardiology. And I think primary care is learning that isn't very efficient. What do I feel comfortable about in my scope of practice? Where can I become more educated and comfortable about having conversations about cardiac health? And what are my extension tools, right? What are physician-to-physician e-consults, right? I mean, for any physician today, they love this, right? The fact that they can step out of the room, have a quick e-consult with a specialist to say, this is what I'm seeing, this is what I'm hearing, here's what I feel comfortable, can you check my work? To me, that is like physician extension at its best, right? And in that model, both parties are being paid, right? The primary care provider is getting paid for the visit, but you're also paying the specialist for their time, but you're not sending a patient through another rabbit hole to go find a cardiology appointment, which we all know is 4 to 6 months, down the road. So I think there's that. I also think this is where technology and wearables, I think, can do a lot for us. I'm starting to see a lot of really interesting wearables around COPD, asthma, cardiology, things that we didn't have before, where again, can we better define what specialty care is? Because I think too often we say anything with heart is cardiology, anything with this is nephrology, anything with that, and those lines are shifting. And I think that's going to be really important for the primary care providers of tomorrow, especially in value-based arrangements. How can they kind of pull specialty care more in their direction? Obviously, specialty care for complex conditions will always exist. And that's where I would go to your point, is the natural alignment has never happened. And so how do you get non-natural alignment? And I think there is where you go down the contracting route, is contracting with specialty care. And ultimately where I've seen success is when you bring them in, to your point, either ownership, joint venture, or wholesale employment, where you can actually manage what is the care delivery model. Because you're right, anybody who enters a specialty office is going to go be put through that specialty care machine with no regards to cost, because that's not their concern. And so I think there's a lot to do with specialty care in the future.
How do we get specialists and primary care providers to begin rowing in the same direction, to feeling aligned?
I'll start. They got to know each other. I mean, I'm constantly shocked when I sit down with ACOs or IPAs, mostly primary care physicians. They're using broad referral. They're saying, well, you go out to the marketplace, like and what does that give us? That gives us patients who are forced to choose on their own. We all know there's no good outcome data, right? So they're just picking some cardiologist that they like or don't like or whatever. And then there's the rumor mill, right? There's, well, so-and-so did my brother's knee and, his secretary got her elbowed. And it's just a rumor mill. There's no data driven. We don't know if they're more efficient. We don't know if they're more effective. And so I think step one is getting to know who your providers are, who are your specialty providers, and doing some really good data sharing. And this is where I agree. I have a lot of optimism for the ASM and some other models that are coming out. How do we get better about being honest about the outcomes on a procedure basis, to be honest, is I think where this needs to go. We need to be able to empower the consumer to say, if I'm getting my hip replaced, I want to go to the place that has the best clinical outcome. And, I think once we put that power in the hands of consumers, just like, you don't go to a restaurant in a foreign city unless you check the Google reviews, right? And so how do we do more of that? I think some of it is in the patient portal side of the things, right? How do we get them to be active members of their care? I think that's a phrase that gets thrown around to say that they don't care. They care. There's just no information for them to actually act on. So I think that would be a great place to start.
Yeah.
I agree. And maybe I'll build on that a little bit. I think something that's going to happen in 2026 is everything changed with quality. Yeah. Everything. So specialists are finding themselves, if they're not in an ACO right now, if you're in an ACO and you're with an advanced APM, you're going to get 0.75%, 3/4 of a point on your fee for service. So the government's finally said it's not going to just be this peripheral shared savings that you're not sharing with the specialist. We're actually not going to give them 0.75%. So if you're not a qualified practitioner under the new quality rules starting in 2026, you may get 0.25. If you're a specialist and you're part of an ACO, you're also going to get the ACO's quality composite score because they've been working on cost, quality, interoperability, improving activities for years. So if you're a specialist and you join up with them and you work and collaborate with them, you're going to get their quality score 2 years later. So imagine if you didn't know that 2 years later, you're going to get 3% bonus on your fee for service. And then you say, oh, I now know that, but you can't do anything about it for 2 years. So I feel bad for hospital CFOs that don't realize that that's coming. So to Juliet's point, time is of the essence. I think those things are going to make people wake up and at least want to start to collaborate together. Derek did mention that in the ACO REACH model, when they build out their provider networks or their specialty networks, they said, specialists, come join us and we will ask you to give us 10% off your fee for service to join us and we'll send you all of our patients. Well, none of that worked. The specialists were not happy. We already have an access issue in the United States. It's very difficult to get into a specialist and even a primary care at this point. So we need to be innovative about unlocking the incentives to the specialist. And it's so wonderful when you figure that out and you start hearing specialists talk to the primaries and say, hey, don't send me this CKD patient or send the CKD patient to me when they're CKD2. I will set them up with a care plan and I may not have to see them for years. So when you start to hear those kind of conversations, super exciting.
Yeah. Well, I want to comment on the quality measures. The changes were huge for MSSP ACOs, where we would historically report through the CMS web interface, and we'd get a sample of 2,700 patients. Regardless of the size of your ACO, you could have 150,000 assigned beneficiaries, and you still have 3,500 patients. Now that's changed with Medicare CQMs. Just a side comment, I've been really impressed actually with some of the EHR data. Connecting to the EHR through the FHIR protocol has really actually closed a ton of gaps. Integrating with all of these data sources has really helped a lot. And Medicare, the biggest change was you may have, let's say, and it kind of goes to churn, where you see more patients than are assigned to the ACO. You may have 100,000 assigned, but you have 200,000 with a primary care visit. That was the population now that you had to report quality. So you went from 3,500, 2,700, 3,000 patients to report quality on 10 measures to now reporting on, for example, Palm Beach ACO is like 240,000 patients. True, there was fewer quality measures. There's 4 last year, but the point I want to make is that when you add specialists they just changed this rule, but at that time, all of a sudden you had cardiologists and these other ACO providers that were seeing beneficiaries. They're now on your quality panel, and so you're like, well, where did this patient's not even assigned, and they haven't seen a primary care doctor. Now we have to do quality on this patient. Nobody's been paying attention to him because that patient's primary is not even in this ACO or whatever it may be. But they just changed that rule. So now the beneficiaries that are in your cohort to report on these Medicare CQMs, I'm specifically talking about Medicare CQMs, now have to have a primary care visit within a year of the performance year. So it makes it a lot better when you're reporting that, and that should shrink the population a little bit. But that was a huge, huge change for ACOs.
Yeah, and I think everything that's been said here is accurate. I'm an actuary, so I think about this from a data perspective, and loved your comment earlier that data is the new oil. I think underpinning all of this, where we've been, where the money has been, where it's going, we need good data to enable these relationships. And I'll even kind of go one further, good data and good structures around that data to make it actionable. And from my perspective, and I have a narrow actuarial lens, as I said, from my perspective, what's really missing here is the data, as you mentioned, to evaluate who are performing well, who should I be referring to, and the models in which can we align our incentives. So I need data to start the relationship. I also need a model to incentivize us so that we're rowing in the same direction, so that we're connected. And I think we're getting there. What we the overall goal here is to treat the highest cost patients. I in this slide, this slide sort of has it implicitly. I have another slide that I often use that just shows the cost curve within Medicare, and all of our spending is within the top 20% of patients. If you've looked at recent performance within these models, you will often find that the highest performers are treating the sickest patients. They're finding ways to align those incentives and actually treat the sickest patients. And often aligning through primary care, I'll put it in quotes because it's not strictly primary care, aligning patients through actually the specialists that are managing those episodes. So a lot of what we've seen are ACOs with pretty narrow types of patients that are already in an episode, a pretty particular episode of care, either post-acute or in need of high management, and aligning those incentives with the docs who are in control of their episode of care. And there is and remains to be, and I would imagine this will go into the future, there remains the highest opportunity within value-based care going forward is going to be amongst the patients who right now we are spending the most on. There are barriers to taking risk for those patients. We need to make sure that we actually get a benchmark that's good enough to take them. If we're getting too many of them in a population-based model, we can get penalized for doing so. I think a lot of the models that CMS is introducing are seeking to break down those barriers. Let me give you a way, let me break down barriers to taking risk to those highest cost patients. I kind of say that's my summary. I think there's been an actuarial barrier to taking risk for those that you truly have the most opportunity to save money on. And I think we're moving in the direction where those barriers are coming down. And I think that's been a big part of the barrier between primary care and specialists is if I'm at risk of getting penalized by engaging more specialists or bringing them into my TIN, that's an analysis we've done for a lot of ACOs. If you acquire a bunch of specialists and have them join into your TIN, there can be a short-term pain in some of these models from doing that. And so I say what I see as the path forward is aligning the models and aligning the data such that we are not putting a barrier to risk that I think there are providers who want to take risk for these patients and want to and see ways to generate good savings on them. And what we need are good data, good models that allow us to flexibly do that and start moving down that path. And again, I think we're getting there. In many of these programs, Medicare leads the way with its models. And as was said, these models may not be the end goal. They may not be anywhere near where we ultimately end up, but I think they're providing very valuable structure. The ASM will probably become an episode guideline for how we could subcapitate beyond even the scope of that program. But I'm a primary care doc, and now I'm going to subcapitate within my risk to these specialists in this way, because I've got a model that's been vetted. CMMI's done an immense amount of work to make sure that the risk adjustment sort of makes sense. And now I have a structure to operationalize. And so that's kind of where I see the path to more integration is just good financial models that allow that to flow freely.
Mm-hmm.
Does that feel like it's inevitable?
Comments on that?
Yeah,
so one thing Citrus ACO was up against, we were in a renewal year for 2025, and we had performed so well, we were going to get hit with the ratchet effect.
Yep.
So all of a sudden, we've been saving, 15 to 20% for years. All of a sudden, our benchmark's going to drop. Even if Medicare gives a little back. And so we actually looked around and we found out, we said that the ACO REACH model would be fantastic for Citrus ACO. The benchmark years are favorable with the benchmarking methodology, and we actually have a higher benchmark. We're actually performing even better under the REACH model than we were. And there's so many aspects of the REACH model that we like, being able to have fee-for-service reduction agreements with, nursing homes and specialists, that we think really can align. I'd love to see some of that into the MSSP program, along with capitation. In the ACO REACH they'll forward you the benchmark. You get a benchmark advance, a payment of up to 7% of your benchmark, which is basically an advancement of your savings potential. Now, if you lose, you take risk, you might have to pay it back at the end. But if you're performing well and you do it right and you run the numbers before you get into it, that's what we did. And it's been tremendously fruitful for us. And it was a very good decision to keep the physicians engaged. We don't like prospective assignment as much because it goes back too far. Doctors are like, I haven't seen this, they're not even really my patient anymore, but I still see them. But that was one of the things that we did. And Physicians ACO and Citrus ACO are a little different, that we've been very static with our participants. We don't add a lot of doctors all the time. Sometimes we've had to let some participants go, but generally speaking, we've been the same population. And so before we add a physician to our one of the groups, we know what we're getting into. We say we know what their benchmark's going to be, we know their opportunity, we know everything about them from a vetting process to where we say, before you even join, we're going to start working with you in like the third and fourth quarter of the prior year to get everything aligned, because the last thing we want is you to come on board, lose $1 million of savings, bring everybody else down, and then they're looking at us like, why would you add this doctor? No, it's not good for anybody, not even our colleague. So, using the data is very, very important. And there's also other strategies. Like, for example, I've, just in the business, working with, tens and tens of ACOs and networking through networks, like there are ACOs that actually have an entire strategy on the arbitrage between the practices and the regional benchmark. So they'll go out and they'll say, we ran data, we looked at all the data, and we found that this practice is operating below the regional benchmark. The regional benchmark, the regional spend on patients, the average spend is 70% of our benchmark. So if they just come in and they operate below that, instant shared savings, and there was an ACO that had about 100,000 lives and ended up with 30 million in shared savings just with this strategy. And it was almost like a shotgun. It's like, we think that it's better to have a lot of density of primaries around in a certain area to make changes in that area. But these were like a shotgun approach, just picking up practices in different markets. And I was like, wow. So that was just a very innovative strategy, I think. I don't know, I hope it leads to good, but it's a way to, find where the money is, which is the topic of this panel. So,
can I make another point just off of something you said about attribution? Because I think at the heart of so many of these models, attribution it's the driver, right? And so, as we mentioned, it's been primarily through primary care. There's some other models that are going to try something else. But I think if you're asking the question, where is the money to be made in value-based care, it's also about who you're not seeing. Right? And so on the other side of the house in Medicaid, where most states do automatic assignment, right? So every member who's a member of Medicaid gets automatically assigned to a primary care physician. You better believe that gets mailed out once. It's not the right address. No one knows. This person has a primary care who's somewhere totally different. And I want to pick up on something else you said as well, Kelly, is the skin substitute fraud and abuse got picked up by ACOs, because when you're on the line for spending, you look at things that you wouldn't have any other reason to, right? And so this is what's also happening in Medicaid, where people are saying, to your point, like, this isn't my patient. And oftentimes there's little fixes to that, which you can build into a contract and yada, yada. But who's the person who's nobody's patient? Because you slipped this in earlier when someone asked you, what are some promising practices? And you mentioned the AWV rate. If I could die on any hill, it's that's the number one thing people should look at, because it's the patients you're not seeing who are potentially your biggest ticking time bombs. And so whether it's an attribution model, as you mentioned, that we prefer in MSSP or even REACH, or it's a mandated model, there's a lot of spending happening by someone who's not being taken care of. And I do think we forget that a lot, right? This is back to the Pareto principle, right? Like, 20% of your population is driving 80% of your spending. And so where are they? And the answer is often they're not engaged. And they're showing up in the ED, and they're clocking through inpatient, and they're eating up SNF costs. And it's exactly what you were saying, right? It's like, go to where the costs are. But I think the second thing I would just add is go to where you're in the dark. Go to where you don't know. This person hasn't been to a PCP. This person hasn't had an AWV in 2 years, right? Like, when we run these lists, that becomes they're my most interesting patients that I want to, like, I just want to go find out who these people are. And oftentimes they have complex stories, right? They're either in a complex family dynamic, complex geographical environment, they're 40 minutes away from anything. That's where you can find a lot of the shared savings as well and suck that waste out of the system, because people who are using an emergency department or an inpatient as their primary care, that's waste, right? That's waste. And we would talk about that as like finding savings, but it's also about reducing burnout of our physicians and just our clinical general infrastructure, because they don't have any business being there. That's not the best place for them. So I just wanted to add that because you mentioned attribution and
So important.
yeah.
Ethan, can I add one thing too?
Yeah, of course.
So all of those things were important, but another piece of the money is the churn of 30% every quarter. So Derek mentioned there's two ways for patients to be attributed. One is prospectively, which they look back a really long period and they say, for the next year, here's your patients, take care of them. But a couple things happen. They pass away or they go to MA. So there's really not a lot you can do with that population. The retrospective way is they look back 1 year, and every quarter they update who's attributed to you, and every quarter there's a 30% churn. And I've been doing this for 12 years and it's still 30%. I don't know how we're not fixing this, although I know somebody who's about to fix this. But it's a churn, and what that really means is the patients you started with in the beginning of the year, they change every quarter. So you're working and you're doing all these great things that Derek's doing. You're coordinating care, you're doing TCMs, you're bringing in the patients you haven't seen. And then at the end of the year, they're not in your final reconciliation because you didn't get everybody in your own. What is the annual wellness visit rate now? Back in 2012, it was 13% nationally.
It's not good. It's way below 20% is the last time I checked
10
it.
years it hasn't gone up. So it's a big area. Where is the money? I think take care of those patients that.
Folks, stay tuned for David, Derek, and AI.
And just to layer in, I'm glad we've gotten to attribution. An interesting, I think it's one of the more interesting areas, and again, a barrier to further engagement and further progress, perhaps. And I think it's one of the solutions, sort of the ratchet effect, right? The ratchet effect is basically we have to keep creating new savings in order to generate savings. Now, there's very valid arguments on how fast we should ratchet. I think the correct answer is don't ratchet too fast. Otherwise, you disincentivize people from even trying. And you maybe incentivize them to move slower to avoid the effect of the ratchet effect. But one solution is finding areas to generate new savings that you haven't saved before. If we look at a graph like this, the specialists, a real interesting question would be, where are all these people attributed currently? Are all of them attributed in the current models? How much of this cost are we even capturing in current models as they stand today? It's probably lower than we think. And I think it's related to an attribution problem. Who is the person that we should attribute the patient to? I think there are a lot of answers that work there, but what we need to define as we sort of merge this primary care and specialist, when we say that, I think we're really talking about a problem of attribution. How can we attribute this patient financially, distribute those financial incentives for changing their cost between who we might determine is the quarterback of the healthcare system, the primary care person, and who we might determine is most in charge of the spending for the most high cost patients that we're going to see, which might be a specialist of some sort. And I think what we still see in the models today is there are providers out there who are struggling to get all of the patients they think should be attributed to them and be able to take financial risk for them. And I think that's going to be where we move this forward, is create more ways for the docs that are in charge or centrally really managing these episodes of care, define these episodes of care, define who's responsible for them, and find a way to, even if you're not fully attributing total population risk to them, find a way to financially attribute incentive to them. And I think that'll be really interesting to see over the next several years.
I think maybe there's also a thing that we're talking about, but we're not naming, right? Which is you're always in competition with,
Yep.
are we doing total cost general population, right? We call that TCGP, right? Where you just say, you're in this geography, you have an ACO that has the, preponderance of primary care, and maybe let's dream big and say specialty care.
Sure.
And do we just shove everybody, and this gets to the attribution question, is like, we just shove everybody who's in Medicare fee-for-service into that model? I'll share, in Europe, they're not thinking that way. And they are doing different types of value-based care based on basically primary disease.
Interesting.
And so, yes, there's always sort of like a general population. They don't call it that, but it's sort of like healthy-ish. That's a very technical term, right? They get one type of model. But then I think to your point about specialty care is like, when you look at this table, right, musculoskeletal is typically a point in time. There's some conditions that are chronic, but for most people, musculoskeletal is a point in time. A hip, a knee, an elbow, right? For some, it's not. It's a chronic condition that they need managed over time. And so I think there is something to learn about European models where they're saying actually the disease state is more, it's driving more of the cost, and that's where we should be thinking about potentially not putting the general practitioner at the center. If you have, and I'm making something up here, right? You have a chronic condition that gets you in front of a specialist once a month, even once every 2 months. I would argue that that's a closer tie than your primary care provider, right? And so I think we're in competition with which model are we putting, our thumb on the scale. And I'm not here to say like one is better than the other, but I almost just want to name it to just say, I think it's something we're still struggling with is, do we want one model for everybody where the benchmark is really hard to get right? The average, I think this is the other point I wanted to just pick up on what you said about the quality measures is so important. I don't think people get it. We've been living in the darkness of average, right? Your sample population, you pick up those population quality measures and we just assume that's what's happening across the rest of your ACO. That's shifting, and that was hiding a lot of nuance and variation. And so I think this newer quality model will do better, but maybe it will make us rethink our strategy and not think so much about TCGP and think more, chronic disease state. I don't know.
And I don't have the answer for it, but just it kind of makes me think of, without taking shared savings from an ACO, somehow giving ACOs access to beneficiary enhancements of, what can we do? Can we send a phlebotomist out to all of the patients' homes to do lab draws, along the lines of quality measures, but also, hey, maybe their numbers are out of whack and bring them in to see the doctor. But it's you want to do it in a way that maybe we could apply with a plan. Medicare allocates these funds that's separate from shared savings to use that towards, getting the beneficiaries more engaged in their health care. That would be, just one idea. I'd like to see, some change there.
Mm-hmm. And we might actually see that. According to the new administration, they recognize that it's been a problem not bringing the patient in, so they've come up with something called the Patient Empowerment Pillar. Not sure what that means yet, other than they
catchy.
It's catchy. They threw a couple ideas out, like we need to get attached to these wearables, Oura rings, all these wearables. We need the care plan to get into these. We need the information that's in these into the doctor's hands. And they even talked about, and I know this is going to make everybody wince a little bit, bringing the patient into the ACO as a participant and potentially incentivizing them with savings.
Absolutely.
So might answer a lot of problems, but it might open up a whole nother set of challenges.
I will just share that I think, and I brutally call it like cutting them in on this. Like, how do you cut the patient in on this? We led some experiments in Medicaid around payment, right? And this was for a very high risk population. So this was individuals living with HIV, right? Where it's like that managing their condition and preventing further spread of HIV, talk about a cost reduction effort, right? Like managing someone's viral load suppression to ensure someone else doesn't catch it is a high value activity, right? And what we came to understand was these are people with multiple doctors, typically who have other side effects given their disease state. Cutting them in worked. Like actual cash benefits to come in and have their viral load level, because this is a very simple care, right? Like if I don't know where your viral loads are, I can't tell you what you need to do next. And so we did some experimentation on this. There were some interesting fintech companies that worked with us on this, because obviously the rules around cutting a check and giving like it's complicated. But what we saw is that it works. It is a patient engagement strategy. They start to understand why we're asking them to do these things that might just otherwise be a bother to them. So I think we've seen some evidence on the Medicaid side of the house that this can work. But I agree, and I just did a quick survey. 3 out of 4 of us are wearing a wearable right now. And I'm not a data privacy expert, and I would want them to be in this conversation, obviously. But I do think people are self-selecting into this, right?
Sure.
People are self-selecting into knowing more about their bodies and their health. And so I think there is a future where carefully curated and protected data should absolutely be part of the patient journey.
And I think a lot of these topics kind of hint at or straddle a concept that I think is important in this, which is we've started value-based care with providers and engaging them in this. They do not yet have all the levers that we would traditionally associate that health plans or a payer would have. And I think as we go further into these models, it will be interesting to explore where we can enable some of those levers that are useful to managing a population, supplemental benefits, narrower networks, or some influence over where secondary care is being provided. Finding ways to connect those dots so that providers can take on a role of sort of a more holistic role of controlling the utilization for a patient than we've had right now. And I think that'll be interesting. We've had hints at it, even in the REACH model. There's subcapitation there that hasn't spread yet, but I think there's hints that there will be indication there, and certainly involving the patients in their own healthcare is something we're seeing health plans start to do. So I think those will be really interesting and important concepts to sort of the next phase of how we move forward with value-based care.
Well, and I just want to make a comment that, Medicare, your CMMI is, they changed the rules for 2026 for the ACO REACH. It was, Medicare would get its profit off the top, of your benchmark 3%, 3.5%, maybe 4% in 26. And then, they changed the sharing. It used to be you would get 100% of your shared savings with some haircuts, quality haircuts, things like that, up to like 25 or 35% of the shared savings. So if you save 35%, which is a lot of, savings, you would get 100% of that. Now it's 0 to 10%. And then from 10 to 20, you get 100% of your shared savings. From 10 to 35 or 10 to 25%, you only get 50% of it. And that would be a great thing. I don't like the haircuts, but what's going to happen to that money? Where's that going to go? That just goes back to the government. They're just tightening the belt. But I mean, something that would come along the lines of, hey, here's a new thing you could do. And I'm not saying I'm not a fan of haircuts either. I think the physicians work very hard for the shared savings, but something better than just that I would like to see.
So there's lots of headwinds. You guys are describing a lot of different eventualities that could come to pass in the next however many years you want to put it, 2, 5, 10 years. But we also have a complex scheme currently. So how do we position properly now to extract, again, the money for where it's at now, while not being flat-footed for the future for where it may be? How do we straddle both lines?
I'll start. I have an idea. So one thing that's really been bothering me is what I'm calling the NPI bounce. So every year around May, you have to decide whether you want to be in an ACO, what type of ACO for the next year. So every year we see TINs, tax ID numbers, and providers go from one ACO to another ACO. Number one, that doesn't lend itself to consistency or learning together. It absolutely wrecks the benchmark for the current ACO. So that's a problem, and I think we need to figure out a longer-term fix for the providers to stay close, because they move based on a deal they think they might get. And the thing that also is troubling me is that the providers, and especially if they're starting to be a little bit of a low-performing provider, they're being cut from these ACOs, and then they're just back out into the street by themselves, and they have to figure out, how do I report MIPS, and how do I report quality, and what am I going to do? So I think there's got to be a better way to keep our arms not only around the flock of our patients, but around our providers, and they have to be put in a right fit. And one thing with working with Jonas so much, we help people across the country get into an ACO that's the right fit for them. Like I said in the very beginning, we just tried to get providers signed up. We just tried to get patients. We figured we'll figure this all out together. But there is really, we call it inside the black box, actuarial science that, in order for you to do this right, you have to know the rules of the government. You have to know these benchmarking rules. And there's no better way than to model out what they're going to look like. And if they don't look good in this particular ACO, let's find them another ACO. Let's just not throw them back out to figure it out. They already have too much to figure out. And this is way too complicated and nuanced for doctors to be trying to figure out actuarially where they best fit. So that's something that I think that we should pay attention to going forward.
Yeah, I'll chime in with, I think sort of the key to the throughout this whole process and getting where we want to go is participation. I think participation is favorable, has been favorable within the Medicare programs. I think it will remain so. Participate and provide feedback. Find out who you're getting attributed that you should be attributed. Find out who you're getting attributed, who you're not being attributed, who you think you should. And I also go down to the patient level. I think what we want to get to is closer and closer to that threshold that you mentioned in your keynote. We want to get to a tipping point because we learn a lot about how this is going to work. So I think the current administration has indicated that's their goal. But what we really want to do is get towards that tipping point of full patient coverage and providers participating in some form as well. Kelly, as you said, in the right fit, but understanding the finances of it, understanding the pitfalls, things you need to avoid to stay financially viable. But that's kind of where I see the future of this going is more participation. I think even in the imperfect state, there's a famous saying, all models are bad or wrong. I think all models are wrong, but some are useful. I think all of these things that CMMI has been putting out are useful. They are also all wrong in some form to some degree, but there's a lot of utility in continuing to engage here and engaging with the incentives that exist today and then pivoting as those incentives hopefully change to better align with things that we want to do. But I think these models are favorable for participation and it should be enabling everybody to dip their toe in and get used to this as a new model of reimbursement.
I actually have a question for our panel, and I was just thinking from like the other side. Is there any advice that you would have for like a specialty group that wants to partner with an ACO or wants to participate in an ACO or align itself closer? Just some thoughts on maybe how can that be, how could they approach an ACO and primary care physicians?
Well, I'll take it, but I think we're running out of time. I would just say it's a good question because most ACOs aren't interested in partnering with specialists. So
Sure.
I think you have to find an ACO that is interested, number one, and you have to come with a value proposition too. You have to say, listen, can I come in and help with your PCPs? Can I help educate them about my particular disease state? What can, or better yet, go to an ACO and say, what can I do as a specialist group to help the whole cause? So I know we're running out of time, but I'll put that out there.
Yeah, I think I just build off of that and just something that you said about, to be in an ACO today, and I say ACO, to be taking on significant risk, let me say it that way, because whether you're in an ACO, an IPA, a value-based deal that you've negotiated yourself, I'm talking about like serious risk, like losing your shirt is possible, right? Two things. One, you should never be doing that yourself, right? First of all, you do need actuarial resources, whether that's in-house, consulted, whatever it is. You need to understand, and to your point, it's like the modeling is the most powerful thing. The other thing that unfortunately, because this is a free market area for the United States, is you need somebody who's connected to other ACOs and can bring you the landscape view. And that's what folks like Kelly and myself can do, is to say, here's what another group is doing. Here's what I've seen work. Here's what I haven't seen work. Here's kind of what's happening. Unfortunately, that natural layer of collaboration just doesn't exist. And so, but they do exist through networks. And so, lots of people know a lot of people and know what has been tried. So I think those two things, I put that like right at the top of the table. I couldn't agree more that if a specialty group, whoever you are, start with the data.
Yeah.
Start working with your ACO just to understand what are you seeing? Like, because I think to get to a value proposition with, I totally agree, everyone makes assumptions, right? If you're the cardiologist, you think it's the number one specialty like you think you're the most important, and that's how all of us go through the day, right? Like, so, you work with the ACO who has access to that data, not just to figure out where the cost is, but where is the frequency? Because if you saw one person and they happened to be the ACO's most expensive person last year, it could have been random. It could be random variation, right? But if you are seeing that maybe you're not the highest cost specialty care provider, but you see the bulk of those patients for whatever treatment or test, whatever it is, that's where you can really work with the ACO to develop a value proposition. So I think it's show up, right? I'd also like to just suggest, like, be a little humble, you know, like I do think there's still a little bit of a power dynamic between specialty care and primary care docs. I challenge either of those people to switch spots for one day, because you probably don't know what it's like to be a specialty care provider. And you also probably don't know what it's like to be a primary care provider. This is why, like, my number one thing is, like, people just got to get to know each other. Like, I don't think people know what it's like for the other person. But the third thing I would advise is dig in deep with the actuarial and consulting services that are available to ACOs to understand what could the value proposition be.
Yeah, I think that's so important. The data is there. It is not pervasive. It is not as simple to access as we might want it to be, and it might be in future. The data is there to make a value proposition to the ACO. And I would also say the primary care ACO is concerned about this. The ratchet effect is real. New savings are going to be required. One way that new savings can be achieved, or that you're going to attack that, is maybe I'm going to engage with my highest cost, highest risk patients more than I have. I need new value propositions. And so if you're looking to engage, come with a value proposition. I think there's data to articulate it, and I think there's openness to explore that.
Can I add maybe just one more thing, which is, I know CMS drives us nuts with their cutoff dates, right? Like, providers have to make choices, calendar years. You can just get started now. Mm-hmm. There's no reason why you can't pretend to be in an ACO. And what I mean by that is, like, come in, right? You're a specialty care provider. Just almost like play pretend, right? Like, just kind of role play some stuff out with the ACO and its providers. Nothing's stopping you. Obviously, you're not going to get access to the shared savings and things like that. But I think we forget that not everything needs to start with a contract. Things can start with a good conversation. And to say, hey, for 3 months, let's do something a little differently and let's just see what happens. Yep. And we don't have to be in a formal contract. I'm making this up. I'm just going to treat your patients a little bit differently in this way. And then let's conference again in 3 months. Let's look at some really good EHR data. You don't have to be in a contract to collaborate. And I think people miss out on that. And then we're all trying to talk to each other on December 31st before we sign a contract. Like, we got to drop that a little bit, I think.
A lot of amazing ideas here. We're down to our final 2 minutes. I think we just go straight up the panel here, take everything we just talked about for the last 58 minutes, and say 1 or 2 sentences, 3 at the most. Where's the money at right now? Value-based care for extraction. Go.
Wow. Where is it for extraction? It's in low quality, low value care. And I think to your other question is, how do you future proof yourself? Focus on quality. That will always win the day. The models will change, but ultimately, if you're focused on quality, you'll always be on the right side of history.
I think it's the right fit. I think making sure actuarially the people are the right fit, so you have the best possible chance to get savings. There is a way to make sure you get savings before you even start doing the hard work. And that's a good thing, because there's more money to give everybody to put back into the system and to make these relationships. So I think it's the right fit. And if you happen to be a low performer, call a network. We will find you a place. Like, nobody should be out there on their own doing this. It's just way too complicated.
Yeah, I would say get help. The data is there to model this stuff out and come up with a financially feasible plan to enter into this, either conversationally or at risk.
Yep. And I would just say, find the right program to participate in, use the data, and, just keep your arms around your flock and make sure you manage your high-cost patients.
Thank you very much.